Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea, Dean of the School of Public Health at Washington University and Editor-in-Chief of JAMA Health Forum. Today we discuss changes to Medicaid, the nation's health insurance program for low-income Americans. Specifically, and more generally, how changes in social policy in 2026 may shape the health of the country. Medicaid is a cornerstone of health access for millions, and this is a particularly pivotal moment for the program. The unwinding of pandemic-era continuous coverage protections have already led to millions losing Medicaid coverage. In addition, new legislation like the One Big Beautiful Bill Act of 2025 threatens to cut federal Medicaid spending by about 14%, or about $900 billion over a decade, and to introduce work requirements for enrollees. These developments could significantly shrink Medicaid's reach. The effects will not be in the abstract, they will affect real people. Vulnerable groups include low-income adults, older adults, people with disabilities, women and children in rural communities. They are all likely to feel the impact of a pullback in Medicaid coverage or services. Addressing these challenges and leveraging opportunities to protect health has never been more important. Here to discuss how policy changes in Medicaid and the social safety net translate into health outcomes is Professor Heidi Allen of Columbia University. Dr. Allen is a professor at Columbia's School of Social Work with a joint appointment in the School of Public Health. She currently serves as a commissioner on the Medicaid and CHIP Payment and Access Commission. She brings a unique perspective as a researcher and practitioner. She is a former emergency department social worker and previously worked in state health policy on insurance expansions. Dr. Allen was a lead investigator on the Oregon Health Insurance Experiment, a landmark randomized study of Medicaid's expansion efforts, and her scholarship centers on how social policies like health coverage and income support affect health, mental health, and financial well-being. Over the past decade, her work in leading journals has informed national discussions on Medicaid policy. I am delighted to be speaking with her today. Dr. Allen, welcome.
Thank you, Sandro. Thank you for having me.
So let's go right to the role of Medicaid and its evolution. So how do you see the role of Medicaid evolving over the next few years? And what are the most important trends shaping its future as a health safety net?
Well, as you alluded to, there are a number of reasons to be concerned about Medicaid in the coming years. One, the economy is uncertain. How we have tariffs, we have war, and we have AI and the implications of AI for the workforce and uncertainty of what that will mean for low-income workers. And Medicaid is countercyclical, meaning spending goes up when the economy is weak. And the changes in H.R. 1, the Big Beautiful Bill Act, means that states are probably going to face some budget shortfalls, and that will put them in a situation where they have to figure out how to do more with less, and they might have to turn their attention towards optional populations that they serve or optional services that they offer. And I think that, as you mentioned, the implementation of the work requirements are going to be a significant challenge for many states. And then I would say the last trend is the aging of the baby boomers into what we think will be the peak years that they might need long-term services and supports.
So I listed the challenges that I see to Medicaid and its beneficiaries right now, particularly in light of proposed federal funding cuts. So how do you think these pressures will affect Medicaid's ability to serve the populations who normally benefit from it?
The cuts in H.R. 1 were contingent upon a significant reduction in federal spending on the Medicaid program. And at the same time, it limited states' flexibilities in the way that they collect money and distribute money to providers, which means that we can expect budget shortfalls. And unlike the federal government, states are not allowed to operate in deficit. And so that means that they're going to be looking to optional populations and programs that they cover and thinking about what they need to cut. Work requirements and frequent eligibility redeterminations, federal guidelines will be released in June, and then states don't have that much time to implement by the end of the year. So that is going to require states to build systems that work, and that's going to be a challenge. But fortunately, a lot was learned during the unwinding of the pandemic continuous coverage era.
So let's talk about that. Let's talk about the post-pandemic unwinding of continuous coverage. So we know that millions lost Medicaid. So talk us through the lessons that we learned about coverage churn and how can policy reduce avoidable losses among eligible populations?
So Sandra, I wrote my dissertation on coverage churn almost 20 years ago, and it makes me quite sad that the topic continues to be so timely. What we know about coverage churn is that during gaps in coverage, care is disrupted, becomes less effective and less efficient. Some people don't get care that they need, and there's missed opportunities to improve health. Also importantly, it puts a tremendous, tremendous struggle for low-income families' finances. And during unwinding, a good number of states improved enrollment processes, including using government data for things like income verification, but it will really matter on how successful they are able to reduce the administrative burden for low-income people as they go through this process.
Take us through the other element that I talked about earlier, which is work requirements. So now Medicaid work requirements are federal policy for expansion populations. So again, based on the evidence, what do we know about their effects on coverage, employment, and health?
We have a couple of studies from Arkansas and North Carolina on their work requirement programs, and they have not shown a positive effect on employment. In fact, in Arkansas, studies showed that most people didn't realize that there were such a thing as work requirements. And I think that one of the reasons that we don't see that positive effect on employment is that 90% of people on Medicaid are in the expansion population are either working or they qualify for an exemption for being in school or being a caregiver. And the remaining population is affected by market forces. So they can have health problems that make it hard for them to work. Older women notoriously have difficulty in the labor market. And the legislation provides an exemption for medical frailty that hasn't yet been defined. And so it's not clear what happens to those 10% of people, some portion of them who might be sick and too sick to work, how the state is going to define medical frailty and whether or not they will qualify for an exemption. But what we find when people lose Medicaid is that a few of them find new coverage that might be a little tricky considering the increases in the premiums or the decreases in the premium subsidies in the marketplace. A lot of people come right back to Medicaid over and over again, and then there's a certain percentage of people who remain uninsured.
Let me break down two populations that benefit from Medicaid. So let's start with older adults and people with disabilities. And let's build on what you said about states earlier. So you mentioned states facing growing Medicaid budget pressures. So how might these constraints affect services for older adults and people with disabilities, and particularly around long-term care and other supports?
When there's a budget crisis, states turn to their optional programs and populations. And one of their optional programs is home and community-based services. We have in the Medicaid program what's called an institutional bias, which means that nursing home care is required by federal law to be paid for by the Medicaid program, and home and community-based services is not. And home and community-based services for the first time recently exceeded spending from nursing care. So what we would expect is that people with disabilities and people who are elderly who may prefer to be at home with supports might end up having to go into institutional care, which is actually more expensive simply because of the way that the federal law is. MACPAC recently released a very helpful research brief that shows the growth of optional Medicaid eligibilities and services over the years, and many of those programs are quite popular. Things like home and community-based services, things like helping kids with special healthcare needs. And at the end of the day, the state has to have a balanced budget, and they have to follow federal rules on mandated eligibilities and programs. So we should expect some cuts that probably will hurt.
Let me move to the other end then of the life course. So let's talk about women and children who also account for a large share of Medicaid enrollees. So talk us through the potential health impacts of coverage disruptions, particularly potential rollbacks on extended postpartum coverage.
Yeah, so I'm actually studying this right now. With Jamie Daw, we have a survey that builds off of the Pregnancy Risk and Monitoring Survey, and it surveys postpartum people 12 months after giving birth. So we're going to have some good data fairly soon here about how they're doing. But in prior research, what we've found is that the Medicaid population compared to people with commercial insurance when they give birth have a lot higher health and social needs. And so what we would expect if there's a retraction of these coverage expansions is that those medical needs will not be met. And when people start to seek care without having insurance, of course, and that puts extra stress and strain on their finances.
And let's talk about the healthcare system itself now. Let's talk about Medicaid cuts and its implications. So how do reductions in Medicaid coverage or funding, what does that mean for safety net hospitals, community health centers, and particularly in rural and low-income communities?
Yeah, I think that there is a lot to worry about there because safety net hospitals and rural hospitals operate on very thin margins. So it doesn't take a lot of revenue loss for them to really run into financial challenges. And that's a problem because rural hospitals have been closing. It's a trend that we've observed over the last decade, and access to healthcare in rural areas has been getting worse, and people are having to travel longer distances for care. So I think that, we would expect that access in rural areas would shrink in response to loss of funding.
About a dozen states have still not expanded Medicaid under the ACA. So with these federal expansion incentives expiring, what do you think is the outlook for closing the coverage gap in those states?
I think it's grim. I'm not going to lie to you. At least a handful of states have been very successful at getting Medicaid expansion through ballot initiatives. And so there's always the possibility that the public will organize and will try to push something through. But I think it's highly unlikely in these uncertain financial times that state legislatures would be pursuing Medicaid expansion.
You've done many interesting things in your career, but one of them, I think, is the Oregon health insurance experiment. Lead us through the most important takeaways from that study about the effect of Medicaid on health, financial security, and employment.
I think that the big takeaway that I have from the Oregon health insurance experiment is that health insurance did what you would expect health insurance to do. It reduced the financial barriers to care and smoothed people's financial exposure to using that care. So all types of healthcare increased when people got Medicaid relative to those who were uninsured. That include outpatient, inpatient, preventive care, surgeries, hospitalizations. We saw improvements in self-reported health, and we saw improvements in self-reported mental health. And we saw incredibly robust findings that Medicaid was financially protective. People were less likely to have a delinquency on their credit report, and that was related to medical debt. They were less likely to be borrowing money or foregoing paying bills to be able to pay for medical care. We did find limited evidence that Medicaid was moving the needle on chronic disease. And some of that may have been related to, we were studying a population that was a Medicaid expansion population. So they were not elderly, they were not disabled. So it could have been a numbers problem, but it was also likely related to the fact that there were fewer tools for managing chronic disease than we have now. Like, this is before an era of GLP-1s. Tools that right now, I think that if Medicaid were to employ, they really could see some improvements in things like diabetic blood sugar control or hypertension. But I think that, it's sad when your study becomes shorthand for Medicaid doesn't work, because that absolutely is not what the study showed at all. It showed that people got access to the care that they weren't receiving or would not have been receiving had they been uninsured.
You've also done work about income support policies. You did a randomized trial of an expanded earned income tax credit. What did that work show about how economic security affects health and how such policies could complement health insurance?
Research on the effects of anti-poverty measures on health is positive but mixed. Overall, I think that programs that improve material conditions for children seem to have the biggest effect on health, and interventions that are targeted and substantive, such as SNAP or housing assistance, seem to be the most effective. In terms of the earned income tax credit, the studies have been mixed, and our study findings were mixed as well. And it's kind of unsurprising because small increases in income aren't really probably sufficient to change health, except in some, maybe particularly small subgroups.
What's the evidence actually show about the relationship between Medicaid coverage and work?
Well, I'm going to speak specifically to the Medicaid expansion program because that's what this policy is targeting. And most people on Medicaid who can work are working. And I think that that's the most important point to make. And then I want to bring up a point that I've been thinking about a lot lately, which is that when people aren't working, if Medicaid expansion truly were a safety net program, we would hope it would function kind of like unemployment and insurance, meaning that people have likely paid into that program over years of unemployment. They've paid into Medicaid when they themselves have not been on Medicaid. And then when they're unemployed, they should be able to access it to help keep them healthy and take care of them if they aren't, and that would help position people to get back to work. There are real things that happen in the economy and people's life that disrupt work or make it hard to find work, including things like factories closing, changes in the economy, and punishing them just doesn't seem fair. And supporters of this policy will say, oh, they can just volunteer 80 hours a month and meet eligibility criteria. And personally, I think that that's just easier said than done. Trying to find a place, I volunteer at a soup kitchen, and, even if I volunteered every day, they would want me there for like 2 hours a day. Like, how would I find the 80 hours required to meet the requirements? So people will have to be putting together multiple volunteer opportunities and doing a wide variety of things to try to meet those criteria, which gets in the way of them trying to find a job. And so I think that the policy is not well targeted for increasing employment. There's a real emerging body of literature on administrative burden, the impact of that on enrollment. And so I think that one of the most unfortunate things about the work requirements is that simply the act of having to reapply frequently, having to demonstrate your income, having to demonstrate your volunteer hours, that there will be a lot of people who are eligible for Medicaid who will be disenrolled and will have trouble getting back on the program or staying on the program.
Thank you. I think if we were able to have that kind of nuanced conversation in the broader public space, we would make different decisions than what we're making right now. Medicaid operates within a broader ecosystem of social determinants of health. So how should Medicaid policy engage with issues like housing instability and financial stress? And what's the boundary between Medicaid and other social programs?
This is an area of lively debate because common sense would say, why shouldn't a Medicaid program buy somebody an air conditioner rather than seeing them multiple times in an emergency department for heat stroke? And that makes a ton of sense. But there's a good counter argument, which is, look how much everything costs in healthcare. Do we really want healthcare to be the middle entity purchasing an air conditioner for somebody? And then the counter argument to that is that, well, all of the money is in healthcare. So if you want to try to address the social determinants of health, you should go where the big budget is. Personally, I think that improving material conditions broadly isn't necessarily well targeted enough to impact health. But I do believe that health insecurity, meaning worrying about your insurance, going through periods of time when you're uninsured, does cause meaningful stress that can be measured in overall health and mental health. And that if we were to simply provide a universal scheme where everybody has basic health insurance, that would be a great investment in a social determinant of health. And it's one that's recognized by wealthy countries in the world.
Despite the current challenges, where do you see the most promising innovation in Medicaid and related social policy? What developments give you some optimism about improving health outcomes for low-income populations?
I am excited about advances in technology, including AI. I think that could reduce prior authorization time. I think it could make it more palatable for providers to work with the Medicaid program if it were less bureaucratic and cumbersome. And so I'm hopeful about that. There's a possibility of, monitoring patients remotely. There's advances in medicine like GLP-1s that I hope will be available to people in the Medicaid program. But both of those positive things come with caveats too, right? Because AI could also be used to make determinations against people receiving care. So I think it requires thoughtful implementation. But it gives me a vision of a Medicaid in the future that could be more efficient and effective for low-income people.
So ending on a positive note, what gives you hope in this moment?
Despite the tax cuts that are targeting Medicaid and HR1, I think that Medicaid is a more popular program than ever. Certainly, it feels more popular than at any other time that I've been studying it over the last 15 years. I feel like that there is a real political constituency behind the program. And I think that when cuts happen to the program, there will be political consequences. At least that's my hope.
I am Sandro Galea. I have been talking with Professor Heidi Allen about Medicaid and the health impacts of social policy changes. Thank you, Heidi, for joining us.
Thank you.
Follow us on JAMA Health Forum and the JAMA Network for more conversations on health policy. This episode was produced by Shelley Steffens at the JAMA Network. To hear this and other JAMA Network podcasts, visit us at jamanetworkaudio.com and jamahealthforum.com or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.